All right, so here we are talking about Chapter 4, the nursing process, critical thinking and decision making. Um, so bear with me. I know this is kind of not ideal as far as lecture goes, but um, with us missing a class time, we need to kind of get on top of things as much as possible. Chapter 21 coming up is super beefy. There's a lot of material to cover, and so I think this is going to be our best way to kind of get on top of things. So, that being said, I'm going to lecture on Chapter 4, and that way, when we get to class on Monday, ideally, hopefully Monday, you guys will be ahead of the game. Um, okay, so decision making in nursing. So obviously, we're going to be talking about critical thinking skills. As a nurse, you're going to do a lot of critical thinking, and it's really important for you to develop these skills as quickly as you can. A definition of critical thinking that I would remember is the use of skillful reasoning and logical thought to determine the merits or belief or action. So to think critically, you need to think about how you think so that you can improve your ability to make sound decisions about patients and their care. Critical thinking is defined as the mental process of actively and skillful perception and analysis, as well as synthesis and evaluation of collected information through observation, experience, and communication that leads to a decision for action. So, critical thinking is basically your pausing to think through a decision. An example of this is going to be like not just doing what the physician asks you to do, but understanding why you're doing what you're ordered to do. So if a patient is having say they have high blood pressure, you need to think critically, why are they getting the blood pressure medicine? Well, it's because they have high blood pressure. What if a patient has a blood pressure of 120 over 80, but they're diagnosed with hypertension and they've been taking an ACE inhibitor for XYZ for so long? You're not going to just not give that blood pressure medicine because their blood pressure is fine because they don't need it. You're going to give it to them regardless because obviously that blood pressure medicine is taking care of that blood pressure problem. So you're not going to hold it. You're not going to hold that medicine. So again, with critical thinking, it's defined as a mental process of actively and skillfully perceiving, analyzing, synthesizing, and evaluating information. That I would remember that. I'll say it one more time. Critical thinking is defined as the mental process of actively and skillfully perceiving, analyzing, synthesizing, and evaluating information. So with critical thinking, you're avoiding jumping to conclusions. You are admitting that you don't know everything and that there could be information that you don't have to help a patient. And you're avoiding making decisions based on assumptions. This is kind of a big one because it's hard to admit that you don't know everything, especially after going through school and learning so much. It can be easy to fall into a pattern of saying like, oh, I know it all, but really there's so much information that you don't have, that you don't want to jump to conclusions because at the end of the day, you're taking care of people and their livelihood, their lives. It kind of depends on you making good decisions and thinking critically properly. Validating So you're validating obtained information. What that means is you're ensuring the correctness of the information that you've obtained. This is going to be the process of challenging what you're told and not just blindly following orders. So you're validating information that you've received. One way you can do this is by double checking your chart according to what the doctor has told you or according to what your patient has said. I actually once had a patient who told me that the doctor didn't want to put him back on his blood thinner because of so and so reasons, and I was a new nurse at this point. And so instead of calling the physician to double check, I went ahead and made the decision to hold that blood thinner. And thankfully, there was nothing bad that was an outcome. There were no bad outcomes because of that. However, my manager did have to talk to me and say, this is a good time to call the physician and make sure you're validating that information, because blood thinner is not something that you just want to skip. Obviously, you could put that patient at a higher risk of stroke. So double checking your information essentially is what validating that information is. Always double check. Always take the extra time it takes to double check. Thinking purposefully is avoiding autopilot. We hear horror stories of people who just go on autopilot and forget their children in the back of their car. And it's just that lizard brain is taken over. They're in a routine, and so functioning on autopilot can and is dangerous, especially when you're taking care of patients. So you want to always think purposefully about what you're doing. This is going to allow you to catch mistakes from physicians. So if a physician orders an antibiotic in the same class that a patient has an allergy to, then you can look at it and think, well, I think this patient has an allergy to the different medication, but is in the same antibiotic class. So I should at least talk to the physician instead of saying, no, I think the physician knows what he's doing. Sometimes they get tired and they don't catch all of the orders. So you could easily give that medication. So say a patient is allergic to sulfonamides, and a physician orders that antibiotic to be given. So you can easily give the patient an anaphylactic reaction, and they could easily die because of essentially negligence, which is autopilot at the end of the day. It's always good to be on alert. And a good example of this, and this wasn't me personally, but somebody I worked with, a doctor wrote an order to be given to a patient 25 milligrams of IV metoprolol. And I'm sure you guys don't understand the significance of this, but you will someday, I'm sure. If metoprolol is given, 25 milligrams is a standard dose if you're taking it by mouth. If we're giving IV metoprolol, I have never ever in my entire career as a nurse given more than 5 milligrams of metoprolol. So the order was IV 25 milligrams of metoprolol. That is literally enough to kill a patient. The nurse that received this order did not think critically, and thankfully there was another nurse to catch this. Praise the Lord, because this literally would have killed the patient. 25 milligrams of metoprolol. She went to pull it out of the Pyxis of the med cart, and there wasn't enough in there. There wasn't enough IV metoprolol in there to give the patient. And so she pulled another nurse over, and that's when the other nurse was like, that's insane. Please do not give that. Call the physician. So, if you ever think that something might be off, always go with your gut instinct. Don't just blindly follow the physician order, because they can be wrong. And the physician said, like, thank God you did not give that. That very well would have killed the patient. So always double check the orders against, what you think. Pull in your colleagues, your peers, call the physician. Always think purposefully. All right, performing the steps of the nursing process, the next slide. So you guys should be at least somewhat familiar with the nursing process by now. That is the ADPI, assessment, nursing diagnosis, planning, implementation, and evaluation. So assessment, hopefully you know by now, is the both subjective and objective data. You will soon learn how to do a head-to-toe assessment, and that is where this kind of comes into play in the nursing process. So assessment is the gathering of information through signs and symptoms, patient history, and objective findings. And it's important for you to understand the difference between subjective and objective data here. So subjective data is something that is known to the patient and to their family. It is something the patient experiences, something that cannot be measured. So an example of this is going to be anxiety and depression, fear and discouragement, pain. Even though we can say, what's your pain on a scale of 0 to 10 to allow us to have an objective data, with pain is always what the patient says it is. It's not something that can truly be measured as much as we try to. It's still going to be very individualized, so pain is very subjective. And if it's subjective data that you're receiving, you need to make sure that you're charting this correctly. So saying that if they have a headache, saying the patient states he has a headache, and then you can chart the objective data that goes along with it, such as grimacing, grabbing their head, stating I have a headache, etc., etc. Objective data is what you can observe and measure using your senses. So that's going to be hearing, smelling, sight, and touch. And again, do not taste your patient. Objective data is vital signs. If they're diaphoretic, you can touch them and they might have cool or clammy skin. Maybe they have foul smelling urine. Other types of objective data are going to be your diagnostic exams, which you need to start becoming familiar with. Diagnostic exams specifically, I want you to become familiar with the CBC and CT scans. You guys have we've kind of briefly touched on urine cultures, or urinalysis rather, the BUN and creatinine. Those are diagnostic exams you guys should become familiar with, and I will further review in our next lecture, but you might see it on the test, so get familiar with them. So that's objective data. Let's see what's next. Excuse me. Okay, interviewing. So interviewing means interviewing the patient, obviously. You're going to establish rapport, which means you're going to create a relationship of mutual trust and understanding between you and your patient. So if I get into the hospital at 7 a.m. to take over care of a patient, you go into the room with the other nurse and you introduce yourself. I'm so-and-so. I'm going to be taking care of you for the next 12 hours. Is there anything I can get for you at the moment? You're just basically introducing yourself, establishing that rapport, letting them know that you're somebody that they will see very frequently for the next 12 hours. Yeah. Obviously, like I said, introduce yourself, explain your role, tell the patient the approximate time of your interview. So if it is just an interview, like a health history or whatever, it might just take 30 minutes. It could take 2 hours. It depends on like the type of interview. Primary data versus secondary data. So primary data is what has been provided by the patient. So the patient gives you that information directly, and secondary data is when information comes from family, friends, or maybe the patient's chart. So that's not something that the patient has given you specifically. Make sure that you're allowing the patient to provide thoughtful responses using that therapeutic communication we learned about. So pausing at the right time, making sure that you're using open-ended questions when it's appropriate. Therapeutic communication you will see repeatedly on your tests. You will see them on the NCLEX, and then in real life, obviously, you're going to use therapeutic communication as much as it seems silly and obvious. And it might be obvious, but you will continue to see it. And then moving on to physical assessment, which we will go into depth. This next lecture. So that's why I'm trying to get this lecture out of the way, because physical assessment is something you will literally do for the rest of your career as a nurse. So get familiar with it, because it's going to be a wild ride. Physical assessment is going to include inspection, palpation, auscultation, and percussion. Inspection is obviously the physical or the visual examination of the patient's body. You're going to look for what do they look like? Do they have an appropriate, and I'm using air quotes here, appropriate appearance, meaning do they look put together or do they look homeless? Do they have, what is their affect or what is their mood like? Is it appropriate to the situation, or is it maybe manic, or are they depressed? You'll look at the integrity of the skin by just visualizing them. So you can see, do they have rashes? Do they have open skin anywhere? Wounds? Maybe skin abnormalities, lumps, etc., etc. And you'll look into the eyes, ears, nose, throat. Anywhere you can see, you're going to be looking, especially depending on what you're doing as a nurse. If you're an inpatient nurse, you will definitely be looking for all of these things. Palpation. So palpation is touch. You're touching or you're feeling with your fingers. You're assessing temperature by palpating the skin, using the back of your hand on their forehead. Maybe you can tell, like, how do they feel? Are they cool and clammy? Are they hot and diaphoretic? Or are they warm and dry, like normal? You'll palpate for pulses, and the radial pulses, the carotid artery, you'll palpate maybe the femoral pulse. So you're going to be palpating for these things. You'll palpate the abdomen to see if there's any lumps or masses. And then auscultation, that's when you break out that stethoscope of yours. It is not just for show. It is not a doctor's stethoscope. You will use that to listen for normal versus abnormal sounds in the lungs, the heart, the abdomen, and then also, like, if they have maybe for dialysis, access for dialysis in their arms, a fistula, you'll use your stethoscope to listen for a bruit. Percussion, this is one of the least used skills in the nursing process for nurses. I have only ever seen a physician use percussion. That's not to say I don't want you to understand what it is, but what I am saying is I've never used it personally. I think it's somewhat outdated. So you can learn about it, and we might we'll show it to you, we'll demonstrate it to you, but other than that, you just might not see it very much. But anyway, percussion is using tapping movements to detect abnormalities of the internal organs. So you will put your finger on some place over the abdomen, and you'll tap the knuckle of that finger with your other hand. And depending on the sound, if it sounds hollow or if it sounds maybe full, they might have excess fluid in their abdominal cavity. So a lot of doctors use this to determine ascites, stuff like that. But as I said before, it's one of the least used skills, and you'll learn it more in depth in the next lecture in chapter 21. All right, moving on to diagnosis. So diagnosis means nursing diagnosis. We are not talking about medical diagnoses. I want you to start becoming very familiar with nursing diagnosis. It is a focus on the needs of the patient. We're not focusing on the medical situation of them. I mean, that is part of it, but it's more geared towards the needs of the patient. So it's a label or a statement for a problem that the patient is experiencing as a result of his or her own medical diagnosis. It is treated by the nurse using interventions to improve the patient's ability to function as normally as possible. And I will say that again for you because I do want you to be familiar with this. It is not a medical diagnosis. It is a focus on the needs of the patient specifically. It is a label or a statement for a problem that the patient is experiencing as a result of their medical diagnosis. It's treated by the nurse using interventions to improve the patient's ability to function as normally as possible. And I'm looking at page 52 of your book. It's got some good stuff on there. So, for nursing diagnosis, you are going to become familiar with how to prioritize diagnoses. The NCLEX loves to test on Maslow's hierarchy of human needs, so I would be quite familiar with it. Get acquainted with it because you are going to need to know it. And if you come back and to complete your RN, you will go even further in depth. So prioritizing. You are going to prioritize based on the physical, psychosocial, and environmental situation of the patient. So ABCs are going to be quite important when it comes to prioritizing your diagnosis. And remember, your ABCs are airway, breathing, and circulation. So if a patient is anxious because they can't breathe, the priority nursing diagnosis isn't going to be anxiety. It's going to be ineffective airway clearance or poor tissue perfusion or whatever, gas exchange, something like that. It's not going to be the anxiety. It's going to be what is the most life-threatening of the situation. And then as they kind of go towards a more stable physical situation, maybe they don't have any airway troubles, no breathing troubles, no circulation troubles. If it's anxiety and risk for infection, then you're going to choose the most important diagnosis of those two once you've resolved other situations. So to select a nursing diagnosis, you're going to select from the NANDA, the North American Nursing Diagnosis Association list, which you should have a list somewhere. If not, you can easily find it on Google. That is, it's a list. Basically, it's specifically written to make diagnoses easy to find, and then it's updated every 2 years based on evidence-based practice. So these are specifically selected for nurses based on evidence-based practice, which is a buzzword you're going to hear quite a bit as a nurse, because we don't just do things because we think it's a good idea. We do things, our interventions are done because they've been studied time and time again, and it has shown to be the best way to intervene with a patient in whatever way that means. So evidence-based practice is something to remember. Determining your nursing diagnoses. So you're going to use assessment data that you collected during the assessment step to determine the correct and most important nursing diagnosis. Defining characteristics are signs and symptoms that are exhibited by the patient that you can attribute to a patient's problem or problems. So again, defining characteristics or signs and symptoms that are exhibited by the patient that you can attribute to a patient's problem. So for example, that's your COPD, or who came in with a COPD exacerbation, who can't go a full sentence without having to stop and catch their breath, or is maybe cyanotic around the lips or around the nails, has a low oxygen saturation. So based off of those physical assessment findings, I would say my priority nursing diagnosis would probably be ineffective airway clearance, and it would be based off of those assessment findings. So you're going to choose the right, most important one, which can be difficult, but because the patient might qualify for several. But again, this is why it's important to remember the Maslow's hierarchy of human needs, which I'll go over in the next slide, and then your airway, breathing, circulation. Always refer back to ABCs and Maslow's. There's a good book or good example rather, in your book on page 54 about prioritizing the nursing diagnosis that you should review. Become familiar with that. It's not going to be regurgitated word for word on the test, but it is a good example of how to prioritize something. And then writing nursing diagnoses. So this is care plans, basically. Your care plans are your nursing diagnoses, and then your interventions and evaluation. So writing nursing diagnoses includes the PES statement, which is a 3-part statement. It stands for problem, etiology, and signs and symptoms. The problem part of the statement is the diagnostic concept or label based on the patient's needs. So that would be the chunk, the actual diagnosis itself. So the problem statement, which would be ineffective airway clearance, or impaired gas exchange, or maybe deficient knowledge, etc., stuff like that. So that's your actual nursing diagnosis, is the problem statement. Etiology is the causative factor, and it's connected to the diagnostic label by the words related to. So your problem statement is ineffective airway clearance. And to connect the problem to the etiology, that's going to say, you're going to say ineffective airway clearance related to, and whatever signs and symptoms that go along that correlate with that nursing diagnosis. So for using that COPD or exacerbation, that would be related to inability to catch breath or shortness of breath even. So related to shortness of breath and cyanosis or cyanotic lips, cyanotic nail beds, hypoxia, low oxygen saturation. And then the signs and symptoms part of that statement is going to include the data collected and the evidence used to support that diagnostic label. So the as evidenced by will be the shortness of breath, etc. See, as evidenced by. I'm writing this down on my sheet of paper so that I can keep it straight for you guys. You've got COPD or exacerbation who's showing shortness of breath and cyanosis with a low oxygen saturation level. They have wheezing in their lungs maybe. They have air trapping as evidenced by a barrel chest. So their nursing diagnosis might be ineffective airway clearance related to wheezing or tightening of airways as evidenced by shortness of breath and cyanotic lips. So that would be a better way to say it as opposed to how I said it before. Because the as evidenced by is going to be the signs and symptoms, basically, which it says right in the statement. That part of the statement is, remember, because it's problem, etiology, signs, and symptoms. So the problem is the nursing diagnosis. The etiology is the causative factor, which would be the COPD. And then the signs and symptoms are going to be what is showing you that this is the problem. What is the patient exhibiting to show you that this is the problem? So, and again, it's important to understand that this is not a medical diagnosis, and so medical diagnoses should be left out of your nursing diagnosis altogether. So if a patient comes in with COPD, you cannot say ineffective airway clearance related to COPD. You need to give the causative factor in a way that you're not diagnosing them, because that's outside of your scope. It's a one-part statement if the nursing diagnosis is a wellness diagnosis. So there are different types of diagnoses that you should review. Readiness for enhanced. If the nursing diagnosis starts with readiness for enhanced, that's how you can tell it's a wellness diagnosis. Not super important for you to memorize, but just understand the difference between these diagnoses because you are going to see them. You're going to need to make care plans based off of them. And then again, if you come back to finish, to get your RN rather, then you will need to go more in depth here. Okay, moving on to Maslow's. So like I said, Maslow's you are going to need to refer back to for, yes, throughout your nursing career, but especially throughout the rest of your schooling and then taking your NCLEX. It can be important information. So Maslow's identifies the human needs in ascending order of importance. And that's something I would remember if I were you, that it identifies human needs in ascending order of importance. So according to Maslow, so he was a psychologist who came up with this theory that we need to have certain levels fulfilled before we can go on to the next level, right? So according to Maslow, the first need was the physiological. So that's your food, air, water, temperature regulation. So making sure that you are in a safe environment. And then he goes on to say elimination, rest, sex, and physical activity. So those are your basic physiological needs as a human. These are the basic things that human beings need to survive. So if you are in a really terrible situation where you are homeless, your Maslow's, according to Maslow's, your physiological needs are not being met because you don't have shelter. You probably don't have a consistent food, or you don't know where your next meal is going to come from. So your physiological needs are not being met according to Maslow's. And then moving on to safety and security is the next level of Maslow's. That's protection, emotional and physical safety and security, order, loss, stability, and shelter. So that is referring back to the homeless person. You don't have that safety and security because you don't have a place to stay. You don't have shelter. You don't have anything over your head. So you're kind of in a pretty bad spot. Third is the need for love and belonging, so meaningful relationships. Fourth is the self-esteem and feelings of self-worth. So that's going to be your pride, sense of accomplishment, and recognition by others. Fifth is the cognitive needs for learning and exploring. So that's going to include knowledge, understanding, and exploration. Sixth is the need for beauty and order. Seventh is the need for self-actualization, personal growth, and reaching your potential. And then eighth is full transcendence. That is the top of the hierarchy. That is when the need to help others comes into play, and once you're able to do that, you are reaching your highest potential. So again, kind of like I was saying before, humans must meet their physiological needs first before needs higher on the steps are of any concern. So that homeless person is focused on where they're getting their next meal, and not so much focused on love and belonging, self-esteem, that beauty, or having personal growth at all. They want to survive. So their physiological needs need to be met before they can concern themselves with anything else. It can be assumed that all of you guys are here because you've reached the self-actualization part of Maslow's, and we kind of can fluctuate on the hierarchy. I think that personally, I'm not saying this because I want to brag or anything. I think that, as an adult, as a functioning, healthy adult, you kind of easily move up higher and higher on the Maslow's hierarchy. So I have moved up to the area of transcendence. But again, you can argue rather that I have maybe some self-esteem issues or whatever. So again, I think that we fluctuate on this, but according to Maslow's, that's what we care about here, not what I think. So you're trying to better yourself and reach your potential by going to nursing school. So we can argue that you've reached the self-actualization part of Maslow's. So your physiological needs are met. Your safety and security is met. You have a place, you have shelter, you have a place to stay. You're not worried about where your next meal is going to come from. You have a sense of love and belonging. You have self-esteem, at least some, in order to function. You have the drive to know more, as far as cognitive goes, that cognitive level. You're into that area of exploration. You desire a need for order and beauty, and then you've gotten to the self-actualization part where you want to see yourself grow more and more. You want to better yourself and further yourself and reach your full potential, and that's a good place to be. So it's important to keep in mind that when you're preparing to teach your patients that they might be on a different level of this hierarchy than you are. So if a patient is uncomfortable, in pain, maybe they need to go to the bathroom, they're too hot or cold, they feel nauseated, hungry, feverish, or anything else. These are barriers to learning, and they need to be addressed before you can effectively teach your patient. And I think we talked about that a little bit like a lecture or two ago when we talked about teaching. If they are not in a place where they can actually comprehend the information because they are in pain or need to go to the bathroom or something, they're uncomfortable, they're not going to retain that information. So address that and then go on to teaching. And the next slide is just kind of a different cartoon that you can hopefully remember it a little bit easier. Like I said, you will be needing to refer back to this quite frequently, so be familiar with it. All right. Planning. All right, so planning is the process of determining priorities and what nursing actions should be performed to help resolve or manage each patient problem. I will repeat that because you might see this on the test. Planning is the process of determining priorities and what nursing actions should be performed to help or resolve or manage each patient problem. Planning involves setting long and short-term goals, planning outcomes, and planning interventions. And planning is the step that comes before implementation in the nursing process. So remember, this whole lecture is about the nursing process. So where are we at in the nursing process? We've gone through A, we've gone through D, assessment and diagnoses. Now we are in the planning stage. What comes after the planning stage is implementation. So we are in the planning stage of what are we going to implement for the patient we're taking care of. And ideally, we would be in class and I could do a case study with you guys where we go through the ADPI process, but alas, this is what we're doing. So, anyway, moving on. So you're going to be making goals for your patient that you can implement. These can be broken up into long-term and short-term goals. And a nursing goal is the overall direction in which a patient must progress to improve a problem. And that's in your book on page 55. You can read that. So long-term goals are not expected to be met before the patient is discharged from the hospital. Of course, that might change if they're in a long-term care facility or a nursing home. And in which case, then yes, they hopefully will have goals that they can meet while they're there. But it is essentially just an ongoing process of improvement or a gradual change in circumstances. Short-term goals, on the other hand, are expected to be met by the time of discharge or transfer to another level of care. So this is your acute care setting, where you have a patient who's on the floor for no longer than like 5 days or whatever, even less or even more. It could be more. It just is all kind of dependent upon the where you're at. Short-term goals can be met in like brief teaching sessions. Yeah. Sorry, I'm just trying to keep my place. Okay. Expected outcomes are statements of measurable action for the patient within a specific time frame and in response to nursing interventions. That's a definition that's in your book on page 55. You can refer to that. Statements of measurable action. So the important thing here is measurable action. Expected outcomes must be explained in measurable actions. This is something that has to be developed by the registered nurse. So this is not something that you as an LPN will develop. However, you will contribute to the plan by giving the assessment and the diagnoses, maybe, basically what you think. So you are an important part of this process. The LPN will contribute information and provide input in the development of expected outcomes. The NOC is Nursing Outcomes Classification. They standardize expected outcomes. So there's a list of 500 expected outcomes that you can use. And what do you think it's based off of? If you recall back a couple slides ago, I talked about evidence-based practice. So these are standardized outcomes that are based on evidence-based practice. And they're designed to specifically coordinate with your nursing diagnosis from that NANDA or NANDA list. Expected outcomes are often the exact the exact opposite of the problem or diagnostic label. So if the nursing diagnosis was self-care deficit related to weakness and pain after surgery, an expected outcome might be the patient will shower with standby assistance by their second post-operative day. That's a good way to state your goal and expected outcome. It gives a clear timeline and goal, and if it's not reached, that's okay. You just have to adjust accordingly. Outcome statements should include each of the following: a realistic specific action to be taken by the patient, not the nurse. They should have an action that the patient is willing and able to perform, and an action that is measurable, as well as a definite time frame for the action to have been accomplished. So your expected outcomes should be realistic. They should be measurable. They should have something that the patient is willing and able to perform. Please include your patient in this process, because if you might have all the plans in the world for your patient, but if they're not on board, none of them are going to get met. So make sure they're realistic according to your patient. And then make sure you have a realistic timeline. So a patient who is in a coma shouldn't be expected to be up and walking in 2 days. That's just obviously not appropriate. And it sounds obvious to you. And we might laugh about it and joke about it, but you'll be shocked by the things that you see in charting these days. So it's important that you're able to measure the outcome. And again, this is the objective data. You want to have objective data to support your outcome. So that's going to be like for that patient who might have some trouble walking. Maybe your goal is that they will be able to walk 30 feet by Tuesday or 3 days from now. When you evaluate the patient's progress, you can definitively say whether or not the patient has accomplished this. So if they didn't walk 30 feet, you can say that the patient walked 15 feet, that the goal has not been met, and then you adjust your goal accordingly. Next slide. Implementation. So implementation, that's on page 56 of your book. Implementation is also intervention. Those words can be used interchangeably here, implementation and intervention. So implementation is types of nursing interventions. This is also nursing actions. These can be called nursing orders. So kind of like your physician that makes a medical diagnosis and gives orders, you're giving your nursing orders based off of the nursing diagnosis. But let's be clear, this is not give oxygen, give medication. Like, you're not prescribing anything. You are doing what is in your scope of practice. So nursing-led interventions that do not require a physician's order. So it may involve direct or indirect patient care. So direct is performed when the nurse interacts directly with the patient. So these are things like bathing, teaching, listening, and administering medications. Again, none of those require a doctor's order, of course, except for administering direct medications. You're going to follow the direct doctor's orders there. And then indirect is the nurse provides assistance in a setting other than with the patient. So that's when you are documenting, you're sitting at the computer documenting for hours. That is a type of indirect care. You're participating in continuing education on your own time, because that's something you will have to do as a nurse. You have to go outside and take classes when you're not at work to renew your license. That is a form of indirect care. Speaking with the provider and then reviewing orders, etc. There's quite a few things that fall into the indirect patient care. Nursing orders can be independent, dependent, or collaborative. So independent are things that can be implemented without consulting anyone else. So again, these are nursing orders that don't require you to talk to a physician to do. So that's going to be bladder scanning a patient with low urine output. Putting a patient on strict I's and O's if you notice urine output is decreasing or trending down. A nursing diagnosis for that patient. So if you have a patient who has a decreasing urine output, and urine characteristics are changing in color. So say they have a clear urine output, clear and adequate urine output, and then urine output starts decreasing, but it's not less than 30 milliliters an hour, that the urine output has been, instead of clear and yellow, has kind of turned more amber in color, then a good nursing diagnosis might be risk for imbalanced fluid volume, because you can assume maybe they have some dehydration issues going on, or they haven't taken in enough fluid. So no order here is required. You just monitor their I's and O's. Maybe you bladder scan them if they're having low urine output. You don't really need to consult a physician to do any of these things. You do need to consult a physician if your urine output is dropping below 30 milliliters an hour, but until then, you monitor by all of those nursing interventions, strict I's and O's, bladder scanning, encouraging fluids, etc. Dependent nursing interventions. So these are nursing interventions that do require an order from a physician. So this is going to be inserting a catheter in a patient who you've noticed has started to retain urine. So say that patient has low urine output, and you bladder scan them and they've got 1,000 milliliters in their bladder. You're not just going to willy-nilly throw in a catheter. You're going to alert the physician, especially if it's a new problem. You're going to alert the physician and say, hey, so-and-so has 1,000 milliliters in their bladder. They're not able to urinate. Would you like to throw in a straight catheter? And they will give you the order to, yes, please catheterize them. So again, dependent, they require an order from the physician. Collaborative orders, or collaborative interventions rather, are those that involve working with other healthcare professionals in the hospital setting. So that's your physical therapy, occupational therapy, and dietitian, or dietary rather. So you're going to be working together with those healthcare professionals. And you'll see that a lot with respiratory therapy, or even dietary. Or I guess nutrition rather. They will come to you. The dietitian will come to you and say, "How is so and so taking in their food? Are they eating?" And you can say, "Oh yeah, they're getting great intake." Or you can tell them, "No, I think we need to supplement with whatever," and they'll agree with you and maybe write that order for you. Initial implementation steps is making sure that you know how to perform the skill before actually doing it. So again, we're in the implementation phase of the nursing process, so that's your intervention. If you do not know how to perform a skill or how to intervene for your patient, don't just do it. Seek help and seek guidance. The implementation steps. This is something you should become familiar with and are on your implementation steps. On page 57 of your book, you're going to need these, especially for your physical assessment head to toe checkoffs. So your physical or initial implementation steps, you're going to check the healthcare provider's order always. You always review that order before executing it, rather than simply going by what someone else has told you that they've ordered. I've actually run into this time and time again where the physician will even tell me, "Hey, I'm going to order so-and-so to get breathing treatments." You can go to respiratory and say, "Oh, hey, Dr. So-and-so is going to order breathing treatments on my patient. Can you get them ready?" But those breathing treatments cannot be given until the actual order is put in. And sometimes they'll forget to put in the order, or they'll change your mind and just not tell you about it. But regardless, sometimes the provider's order will not be there when they say it's going to be. So don't ever do something without the order. You can't just say, "Oh, well, he's going to put it in, so I will just go ahead and get it done." No. Make sure you have the order before you do the intervention. Refer to your facility procedures. Something that you're going to want to become familiar with is your facility policies and procedures. Gather the needed equipment and supplies. Make sure you always have extra supplies. If you're going to go in to do a sterile procedure, especially have extra sterile gloves. Wash your hands and follow the facility policies and CDC guidelines for hand hygiene. Obtain assistance if needed. Always have a friend, especially if you're doing like a Foley or something. Have a Foley friend with you. Identify your patient using 2 methods of identification, such as name and date of birth. Always ensure that you're providing ordered care to the correct patient. That's important. Introduce yourself to the patient, explain the procedure, provide privacy, use standard precautions or, more strict precautions if necessary, just depends. And then make any assessments needed to ensure that the patient still requires the procedure and is able to tolerate it. So that's going to be especially for things like suctioning, suctioning a trach. You're always going to auscultate the lungs and make sure that they actually need it before you just go and do it. And then continue to observe the patient during the procedure and then after. And then the ending implementation steps are evaluation. How did they tolerate it? Was the procedure effective? If you had to do trach suctioning, for example, you'll listen to breath sounds again to make sure that they have a clear airway. Make sure that they can access their call bell, they're in a comfortable position. Obviously lower the bed, perform hand hygiene, ask if they need anything, document, dispose your supplies. And the next slide is evaluation. So this is the last step of the nursing process evaluation. Are the nursing diagnoses correct? That's one of the things that you want to evaluate. If the patient has complained of pain and you give pain medicine to evaluate the effectiveness of your interventions, what do you think you're going to need to do? So the patient has complained of pain and you've given pain medicines to evaluate the effectiveness of your interventions. I would reassess their pain. So say I gave oxycodone at 1200 and it is 1230, I would go back in and say, oh, how is your pain, Mr. So-and-so? And he would tell me, well, ideally he would tell me it's all gone, or he might say, oh, it's still there and I need more pain medicine. So you're going to reassess and then re-intervene depending on the evaluation. So have you established realistic and reachable goals? Is the person in a coma actually going to be able to walk again in 3 days? No, he's not. Unlikely, anyway. I'm not going to say no, but unlikely. Please maybe readjust your goals based on the patient presentation. Have you determined the correct priorities? Is your COPD who has ineffective airway clearance, is their top priority going to be anxiety? No, it's going to be ineffective airway clearance. Make sure you determine the correct priority. And then selecting and implementing the correct intervention. So for that COPD, it's going to be, sitting them up, administering oxygen, maybe a breathing treatment, and then has the patient's condition changed? So did sitting them up and giving them a breathing treatment and maybe giving them oxygen, did that help their status? Are they short of breath still? If no, then yes, then all of your goals have been met. You have successfully fixed that one problem. Hopefully you will continue to have that response, right? But as you can see here, the nursing process is basically a never-ending cycle. It's going in a loop. You are assessing, making a diagnosis on that assessment. You're planning, you're intervening, and then you're evaluating. And then based off of that evaluation, you're going to make another assessment, and then you're going to make another diagnosis, and then you're going to make another plan, intervention, evaluation. So you're kind of constantly going through this cycle throughout your day or your shift or whatever you're doing. Your patient who has COPD, who's got hypoxia when they come in, you throw on, you make the nursing diagnosis that they have impaired gas exchange, so you put oxygen on them and sit them up. That was your assessment, nursing diagnosis, your plan, and intervention all at one time, basically. And then within minutes, you're going to see how did that oxygen and sitting them up, how did applying oxygen and sitting them up help them? Well, their oxygen level came up to 95 instead of being 88. Well, that's great. You basically helped your patient. So now you can move on to the next problem, right? Or, applying oxygen didn't help them. Their oxygen sats are staying at 88. All right, well, let's readjust the plan, and you continue on. So, like I said, it's a cycle, and it's a cycle that you probably won't even realize that you're doing continuously, but you really are. And then that's just another cute little graphic of steps in the nursing process. We say add pie. Some people say, a delicious pie or an apple pie. So apple is instead of delicious, and it stands for analysis. But I prefer add pie. All right, here's a little mini case study. Super mini case study. 65-year-old male presents to the ED complaining of shortness of breath. What are you going to assess? Patient complains of shortness of breath, 65-year-old male. What are some of the things you're going to assess? Go ahead and think about them for a second. Alrighty. So if a 65-year-old male comes to the ED complaining of shortness of breath, the first thing I'm going to do is get a set of vital signs. Next thing I'm going to do is auscultate or listen with my stethoscope to their lungs. What do their lungs sound like? I'll listen to their heart. What does their heart sound like? What is their appearance? So you're going through that nursing process, the physical assessment, inspection, palpation, auscultation. So you're going to go through that assessment process and then the nursing process. So first is assessment. What are you going to assess? Auscultation, you're going to get vital signs, etc. So upon auscultation of the lungs, you hear inspiratory wheezes in the upper lobes bilaterally and the middle lobe on his right lung. Lung sounds are diminished in his bases bilaterally. Vital signs, I'll let you read those vital signs. And he speaks in short sentences, but is able to tell you that he smokes 2 packs of cigarettes a day. Just take note, what is the subjective and objective data here? I would start differentiating here. What is it that he's telling me, and what is it that you're finding? Become familiar with that subjective and objective data. Diagnoses. What are the nursing diagnoses for this patient related to the problem he's experiencing? What do you think the priority diagnosis would be based off of these vital signs? His oxygen is at 87%. His respirations are at 26%. He is speaking in short sentences, which means that he's quite short of breath. That is a very good indicator of shortness of breath, is inability to speak in full sentences. And then when you listen to his lungs, you hear wheezes. So clearly he's in some sort of respiratory distress, according to these vital signs. So the nursing diagnosis for the patient, the priority one that I would say is ineffective airway clearance, possibly related to bronchospasm, maybe increased mucus production. We don't really have all that information yet, but I would say related to whatever that problem is, and as evidenced by decreased oxygen saturation, wheeze, shortness of breath. A different or other diagnosis, which is important but not as important as ineffective airway clearance, is impaired gas exchange related to, and then as evidenced by. Then ineffective breathing pattern because of their shortness of breath, and maybe deficient knowledge would be last, and deficient knowledge because of the smoking, right? So some good diagnoses here. What are your priorities for this patient be? Priorities, the first thing I would do when I found these vital signs is I would sit him up. I would tell him to stop talking, please shut up, and put oxygen in on him and ask him to take deep breaths in through the nose, out through the mouth, right? You're trying to relax the patient, get him to stop using up all of his oxygen by talking, and you're sitting him up to allow for maximal lung expansion. What nursing actions should be performed to help resolve or manage each problem? Well, I kind of just said it. And then what are the expected outcomes for the patient? Expected outcomes that I would say is within 15 minutes or less, hopefully, his oxygen saturations will come up after applying oxygen, right? Shortness of breath will diminish. Some goals. These are your goals. Correct your hypoxia. Open those lungs back up by correcting the underlying problem. Maybe they have bronchospasm and need a breathing treatment. You would have to talk to the physician and let them know, but that would be something that you could correct easily and restore homeostasis, which is restore them to their normal baseline. And then eventually you're going to educate them once you've taken care of the most basic of problems, and refer back to Maslow's, which is the physiological problems. Can they breathe? Once you've restored that basic problem, and get them comfortable again, you're going to educate them. You got to stop smoking. So yeah, that's your planning. Implementation. So you're just going to implement each thing that I've just said. Raising the head of the bed, giving oxygen, maybe a breathing treatment if that's what's necessary. So that's your implementation, your interventions. Apply oxygen, get an ABG. So we haven't talked about these yet, but we will. ABG is an arterial blood gas, which gives us more information about the actual gases inside of the bloodstream. I wouldn't worry about that right now, but this is something that you will see again in the future. Nebulizer treatment or breathing treatment. If ordered to open up the lungs, maybe they need a chest x-ray. Oh, and yeah, their blood pressure was high, and I forgot to mention that. Antihypertensives and maybe anti-anxiety medications. And then you educate. How do you think that you're going to evaluate whether or not your interventions worked? Well, did their oxygen saturations come up, right? When you listen to their lungs after a breathing treatment, what did they sound like? If they did get a chest x-ray, if the physician did order a chest x-ray, what did it look like? If you gave antihypertensive medications to bring that blood pressure down, did it work? And then the response to being educated, did the patient say anything about his education, or was he just not receptive to it? So again, it's the evaluation. So your patient's oxygen came up to 94%. Their ABG was normal. Chest x-ray showed enlarged lungs and air trapping, which is indicative of COPD. The patient's respiratory rate decreased to 18 breaths per minute after their breathing treatment. Blood pressure came down to 140/88. That's not perfect, but that's probably their baseline, and it's definitely a lot better than what it was. And then you educated him about smoking cessation, and he stated, I really need to quit smoking. So that is a good little example of the ADPI process. And so after this, after all, you're not just done with the guy's care. You can't just ship him off. You would move on to the next problem, right? So if so their oxygen's at 94%, I say on 2 liters of oxygen or whatever. You're going to move on to what's next, which might be their deficient knowledge. Maybe it's anxiety, and you continue on with the nursing process. Alrighty. Roles of the RN and LPN in the nursing process. So the American Nurses Association is the ANA, and according to their standards of practice, the nursing process, all steps of the nursing process from assessment through evaluation are the responsibility of the RN. According to the National Federation of Licensed Practical Nurses and their nursing practice standards for the licensed practical and vocational nurses, they identify assessment and nursing diagnosis as the responsibilities of the RN, while the LPN and LVN participate directly in the remaining steps of planning, intervention, and evaluation. So this is kind of where things differ a little bit. The ANA thinks that all steps of the nursing practice are the sole responsibility of the RN, while the NFLPN think that the steps of planning, intervention, and evaluation are responsibilities. You share that with the RN. You share those responsibilities. That for you guys is the your standard of practice that you should follow. So you are going to be planning, intervening, and evaluating. So just because the ANA says that the assessment through evaluation are the sole responsibility of the RN, you will listen to the NFLPN and help with the planning, intervening, and evaluation steps. Just want to be clear, you guys are not going to be tested on these, but you need to know what your scope of practice is to avoid getting in trouble. So you're not going to assess and you are not going to diagnose, but you are going to help plan, intervene, and evaluate. All right, so what types of nursing intervention requires a healthcare provider's orders before they can be performed? So this is kind of going back to the nursing process, the nursing orders stage rather, implementation. What, as a nurse, as an LPN, can you do that requires a healthcare provider's orders? And that is dependent. So that's the type of nursing intervention that requires a healthcare provider's orders before they can be performed. So that's going to be giving or catheterizing your patient, giving that breathing treatment or whatever. Yeah. Alrighty. Nursing care plans. You guys have got it so good. When I was in nursing school, man, our care plans were like 20 pages long. And we would spend literally hours after clinical. And they were due the next day, if not the same day. As a nursing student, and we would have to go to the hospital the night before clinical to pre-plan on our patients. So count your blessings. Nursing care plans are not just things that you do in nursing school as busy work. You will see them in the hospital setting. Most hospitals have computerized care plans, though, at this stage of the game in this day and age. The RN is going to highlight or check appropriate nursing diagnoses and goals and interventions, and the care plan will be available to all nursing staff. Standardized care plans, those are the pre-printed documents with typical nursing diagnoses and interventions that will coordinate with particular medical diagnoses. An example of this is a standardized care plan for pneumonia might be ineffective airway clearance, impaired gas exchange or activity intolerance, and there will be interventions for each. Multidisciplinary care plans, those are a collaborative approach to care plans. Those provide space for other members of the healthcare team to document their own plans. So, like if a doctor has their own care plan, which you're not going to see that, but like maybe respiratory therapy, that's a good example. They will document what they did, what they think is a priority for the patient, and you'll be able to see kind of all of these things, and also like what is your role in all of those. Critical pathways are also known as clinical pathways, similar to standardized care plans, but they're based on progression expected for each day that the patient is in the hospital. So there's a bunch of goals that should be met throughout each day. So for like, say a patient is post-op day 1 of an open heart surgery. Based on evidence-based practice, there will be a set of goals for every patient, and it's not as specific, unfortunately. That's kind of the problem with these pathways. And it's not super patient specific, but based on evidence-based practice, there are going to be a set of goals for each patient to meet. And if they're not meeting those goals, then you readjust them. But so an example would be post-op day 1, patient should be walking. Every post-op day 1 open heart surgery patient should be walking. That's an expected critical pathway or clinical pathway. Student care plans. So these are the care plans that you guys do as students. These are obviously way more detailed than you're going to see in the clinical setting. So you're obviously not going to see 20-page care plans in the clinical setting. This is what you guys do in nursing school to kind of allow you to develop and sharpen your critical thinking skills. These are important. Not something I would take lightly. I know it sucks, and they can be busy work. And I don't know if you guys have done a whole lot of nursing care plans, but they really do help you to develop your critical thinking skills, because you can think through like what's important for this patient, what did I do that helped this patient, why are these patients taking these medications, and so don't take advantage of this opportunity because it's busy work. Just try and do what you can to learn the most you can, right? All right, off my soapbox. What type of nursing care plan provides daily nursing interventions that change as the patient improves? It's going to be your critical pathway. These types of nursing care plans are similar to standardized care plans, except that they are based on the progression for each day the patient is hospitalized. You guys have a responsibility to read your book. I would be familiar with the care plans and the types of care plans. I'm not going to spend a ton of time. Obviously, I did not spend a ton of time covering those. Unfortunately, there's just not enough time for me to do it all because of the stupid hurricane. But so make sure you guys are reading your books, please. That way you guys are getting all the information. Obviously, I'm posting this on Canvas, so I just want you guys to be aware of everything. Preparing for care for patients prior to clinical experience. Okay, so this is talking about pre-planning, which you guys do not do anymore, which is fine. You guys, that's kind of a big load off when it comes to nursing school. There's no pre-planning. So what we would do when I was in nursing school is the night before our clinical, we would go into the hospital or wherever we were going to have our clinical for the day, and we would pre-plan on the patient we were assigned to have. So our assignments would be made the day before clinical. And so I would go in and I would open up the chart and get all the information I could on the patient that I was going to have. So that's the research part. Based off of that research, I would come up with possible nursing diagnoses. Then I would come up with expected outcomes for the day that I was going to have them, develop the interventions for that day. And then I would meet the day of. This would be the day of. I would meet and assess my patient. I would evaluate my nursing diagnoses compared to what I prepared the night before. I would implement the interventions that I prepared the night before, and then I would evaluate my care plan. So basically the nursing process, just this is what you guys are being saved from. These are just slides that were included into the book PowerPoint, so I just left them in. Don't worry too much about all this. Concept maps. So this is something that you guys should be familiar with as well, also known as mind maps. It kind of helps you to develop that critical thinking. You have basically the problem in the middle, patient with coronary artery disease, chest pain with exertion, and then you've got maybe your nursing diagnoses underneath, and then implementations based off of those nursing diagnoses, and then up as well. And then you might have an extra box for medications and stuff like that. So that's about it for chapter 4. I very strongly encourage you to read your book. There is a wealth of information in there that you should be familiar with. I already said it before, but I'll say it again. The diagnostic exams that I want you to be familiar with is the CBC, which is a complete blood count. You have hopefully already reviewed the urinalysis, the BUN and creatinine from urinary. So go ahead and get familiar. What kind of assessment data is that? I think that's it. I expect to see you guys on Monday. It is Wednesday, so I expect to see you guys on Monday. Our first test will be Monday, so come prepared. Please come prepared. Listen to this slide or this lecture. I know it's difficult and it's probably really boring just listening to me talk, but at least you get to do it at home, right? And you can re-listen to this as you need it. And again, read your book. Oh, and then that assignment I assigned you guys to do, I think it were pages 166 to 170 in your fundamentals study guide, and it's just a documentation exercise to prepare you for our chapter 21 lecture. Please read that chapter. Please do that assignment. I will count it as a grade. So come to class prepared on Monday. Most importantly, stay safe for this hurricane, and I hope you guys have an at least somewhat restful, unexpected time off. All right, thanks.